So hello everyone. So the management part of cystic fibrosis will be discussed in this presentation. Cystic fibrosis part 1 is where I have discussed the pathology, the genetic and the clinical features, and we finished off with the diagnostic criteria for cystic fibrosis. So let's begin the management. So any cystic fibrosis patient will need a holistic approach because cystic fibrosis is a progressive multi-systemic disorder. So start with the respiratory management. We have to give them nutritional care. Pancreatic enzyme replacement therapy has to be given. Their mental health has to be addressed along with the holistic care for the family members, screening of the siblings, and anticipation of other organ dysfunction like cystic fibrosis related diabetes, etc. They have to be under regular follow-up and giving them the age appropriate or the catch-up vaccinations. So let's start with the management of a cystic fibrosis lung. So there are many therapies that have come, especially the gene therapies are coming up, and there are many newer drugs which are coming up. So there is a possibility of gene replacement which could target the defective CF gene. There are many drugs which I will be talking about in a moment which will assist in the proper protein translation and the protein repair. The abnormal airway surface milieu can be altered. The airway clearance technique, especially usage of hypertonic saline, the airway clearance with recombinant human DNase, and treatment of antibiotics, giving them good prophylaxis, and inflammation or hypersensitivity reactions like ABPA should be treated with corticosteroids. And finally, if it is an end stage pulmonary disease like a bilateral bronchiectasis, lung transplantation is the option. So starting from the gene therapy, it goes on a longer path. So let's start with the airway clearance techniques. CF patients will have impaired mucociliary clearance. So we have to help them up with good chest physiotherapy and adequate hydration. So chest physiotherapy with postural drainage has to be done, and physiotherapists who are expertise under respiratory care. So the respiratory physiotherapists are the one who should be employed to take care of cystic fibrosis patients. So there are many different techniques of airway clearance for infants and young children. Postural drainage and just chest clapping technique. So just chest clapping anteriorly, posteriorly and in the axillary area is done. This is for infants and young children. When they get older, for older children, cyclical breathing technique has to be taught. Autogenic drainage technique also has to be done. In adolescents and in older children and adolescents, adults, there are specific devices like a positive expiratory pressure device, high frequency chest wall oscillation. So their vests will be available which will oscillate the chest wall in a very high frequency. So the patient is expected to wear a vest and then there will be high frequency oscillation is given. So these are all given for adolescents, older children and adults. Flutter therapy is one another airway clearance technique. So these airway clearance techniques require special devices and of course require special training also for the paramedical personnel. So the airway clearance, why are we concerned about the airways? Because we know that in the cystic fibrosis patients, the mucus will become very viscid, isn't it? So that is very difficult to clear for the patients. So because of the alteration in the mucus, that is in the airway surface liquid, there is bacterial colonization that causes bacterial infections and that will damage the respiratory tract. So what we do? We give hypertonic saline nebulization. Before hypertonic saline nebulization, what we can do is we do a bronchodilator nebulization with salbutamol. After that, it is followed by giving hypertonic saline nebulization. Between 3 to 7% hypertonic saline can be given. So you give a bronchodilator nebulization, follow it up with a hypertonic saline nebulization and give a good chest physiotherapy. Ask the patient to cough and then clear off the secretions. So this has to be done in this manner. One mucolytic agent that we use in cystic fibrosis patient is of course the N-acetylcysteine, isn't it? So N-acetylcysteine. So this will reduce the viscosity of airway secretions, and the NAC has a very offensive odor. For those who have used, you will know, and it also can cause some hemorrhage and bronchospasm. So it is used is very, very limited when other measures fail. Nowadays, we use mucolytic agents, advanced agents like a recombinant human DNase. Okay, this is more preferred when compared to NAC. So, in cystic fibrosis patients, what happens? There is a high concentration of DNA in that viscid secretion. So much of inflammatory cells will be there, neutrophils, lymphocytes, etc. So, these will start releasing the DNA. So, we need some molecule which will go and lyse the DNA. So, we give DNase, we give recombinant human DNase as a aerosolized form. Okay. So, when we give aerosolized recombinant human DNase, it will increase the mucociliary clearance, and this has very few side effects like some voice change and mild pharyngitis can be there. So, this is used. But there is no role for bromhexine, ambroxol, oral mucolytic drugs. There is no role. Okay. No role for oral mucolytic drugs. Next, coming to the hypertonic saline inhalation, I told you 3 to 7% of hypertonic saline can be used. Hypertonic saline will also increase the mucociliary clearance, and it will increase the mucociliary clearance, and it will improve the lung function. So, before giving hypertonic saline, always give a nebulized bronchodilator like salbutamol, and then you follow it up with the hypertonic saline. So, this is all for the mucociliary clearance. So, we started with airway clearance technique like physiotherapy, postural drainage, and age-wise airway clearance technique I told you. Along with that, nebulization techniques, what are we using now? So, bronchodilator, follow it up with hypertonic saline, and recombinant human DNase is also used nowadays. Okay, no role for oral mucolytic agents. Now, coming to antibiotic therapy. Commonly encountered microbial agents which cause pulmonary exacerbations, we have already seen Staph aureus, Pseudomonas aeruginosa, Burkholderia cepaceae complex, Aspergillus, and fungi, isn't it? So, these are the common microbial agents. So, how are we going to treat it? First, we should know whenever the child has an acute exacerbation, we should be able to isolate the organism. So, a throat swab is taken, deep throat swab, cough plate technique, and it is done usually after physiotherapy to increase the yield of the sampling. So, Pseudomonas infection and Burkholderia infection, both of these organisms, they are associated with an increased mortality and increased morbidity. So, for Pseudomonas, the parenteral therapy, that is IV antibiotics are given, which includes any of the following: ceftazidime or cefoperazone, piperacillin, imipenem or meropenem plus aminoglycoside. So, it can be gentamicin or amikacin, right. So, this is the IV parenteral therapy for Pseudomonas infection, and inhaled antibiotics can also be given, but parenteral antibiotics plus inhaled antibiotics should be given. Just inhaled antibiotics will not work. So, the inhaled antibiotics usually given are tobramycin, colistin, azithromycin, etc. So, this role of azithromycin is being increasingly reported that it has a good anti-inflammatory and an immunomodulatory effect. So, because of the anti-inflammatory and the immunomodulatory effect of azithromycin, 3 days a week azithromycin orally is given for patients with cystic fibrosis. In case we don't, there is no yield, the cultures are negative, we will not be able to identify the organism, a combination of Pseudomonas and staphylococcal coverage has to be given empirically. Depending on the patient's response, the duration will also change. So, usually minimum 2 weeks we have to give. Okay, minimum 2 weeks IV has to be given. So, IV ceftazidime or cefoperazone or imimiro, anything for minimum 2 weeks, maximum for 4 weeks, and then maintained on oral azithromycin. So, next is about the oral antibiotics. So, whenever there is an acute exacerbation, first we start with oral fluoroquinolones, and then if the patients, the hospitalized patients will be shifted to parenteral antibiotics. So, what is this acute exacerbation? We should know, isn't it? So, any child with cystic fibrosis, you know what is the baseline of the child. So, baseline level of cough or what expectoration the child has, does he have any fever, everything you will know. If there is an increase in fever, weight loss, cough, expectoration, he is not gaining weight, despite you giving good pancreatic enzymes, the child is not gaining weight. So, all this might indicate a acute exacerbation. So, whenever there is an acute exacerbation, starting of oral antibiotics early will be beneficial. When the patient's condition deteriorates or he is hospitalized for some reason because of respiratory distress, need for oxygen, etc., IV or parenteral therapy is given. So, aerosolized antibiotics, just I mentioned, tobramycin, colistin, aztreonam are all given. Azithromycin is low dose azithromycin, means 5 mg per kg. So, maximum 15 mg per kg. So, even this low dose 5 mg per kg has a beneficial effect on lung disease. So, it can be given 2 to 3 days a week. So, that will reduce the that will reduce the exacerbation that the cystic fibrosis patients have because of the anti-inflammatory and the immunomodulatory effect. So, coming to the steroid therapy, generally cystic fibrosis patients will not require steroid therapy, but a subset of them, if they are associated with hyperreactive airways, these patients might need inhaled steroids and inhaled bronchodilators. So, what about oral steroids? Oral steroids again is given only in ABPA. ABPA, there is a separate presentation in which I have talked about the oral steroid regimen. 2 regimens are there, regimen A, regimen B, and how are we going to give oral steroids, what is the treatment of ABPA, antifungals, etc. So, please refer to that. So, in case if you diagnose aspergillus, allergic bronchopulmonary aspergillosis in a child with CF, treatment is very necessary because that will lead to morbidity. So, coming to the nutritional management. So, these children with cystic fibrosis usually achieve normal growth and development with adequate pancreatic supplements, but not just the pancreatic supplements, we have to give them a good diet chart. Their diet should have increased calories, we have to give them fat-soluble vitamins, and we have to replace the pancreatic enzymes. So, these children's diet should be high in calories, high in proteins and high in fat. So, we can ask them to take milk powders, preparations of groundnut, preparations of coconut, etc. So, high protein, high calorie and high fat. Extra salt intake also is advised for these patients. In case there is, even after adequate calorie intake and giving good pancreatic supplements, the child shows no weight gain, then nasogastric feeding or a gastrostomy feeding is done for these patients, because whenever there is a poor oral intake, the rate of acute pulmonary exacerbations also increases. So, these are the doses for vitamin E and vitamin K that you can refer. Water soluble vitamin deficiency is not that common. So, we have to supplement with A, D, E, K vitamins. Sodium supplementation is recommended in hot climate, that is in summers, because they lose a lot of sodium chloride through sweat. So, the daily salt intake of 2.5 gram is enough for less than 10 kg. For 10 to 20 kg, they need 5 gram salt. For more than 20 kg, 7.5 gram salt intake is needed. So, vitamin A and vitamin D doses are also given here for reference. So, coming to the pancreatic enzyme supplementation, these pancreatic enzyme preparations are usually available as enteric coated capsules or microspheres. So, these will contain the pancreatic enzymes, that is amylase, lipase and protease. Okay. So, they contain amylase, lipase and protease. So, this is given as, this can be swallowed as such in bigger children, or it can be broke open, sprinkled over the food of infants and young children who will not be able to swallow the capsules. So, the dose of enzyme will be from 3000 to 10,000 per meal depending on the caloric and the fat intake. So, based upon the weight gain, based upon the stool consistency, if it is still so much of very high fat content in the stool, bulky stools are there with offensive odor. So, based upon that, the dosage will vary. So, these are the pancreatic enzymes. Many of you would have seen this. So, it is available as Creon capsules. So, it is available in different strengths from 10,000, 25,000, etc. So, these pancreatic enzyme replacement therapy, remember, it can be started even if at least 2 or more than 2 abnormal condition is present. So, that 6 criteria which I told you, you can refer in the previous presentation. So, even if that is present, please start pancreatic enzyme replacement therapy, and then meanwhile you can arrange for sweat chloride and genetic testing in the child. So nowadays there are many newer gene therapies have come. When we studied, we had only one drug, ivacaftor. So nowadays there is ataluren, tezacaftor, lumicaftor, etc. So these gene therapies are trying to potentiate the CFTR protein translation, its function, and characters also. So gene characters are also available. So this ivacaftor, tezacaftor, and one more drug, elexacaftor. So what ivacaftor does is, it will potentiate the opening of the chloride channel which is at the cell surface. So this can be used only for those mutations where the CFTR protein has already reached the cell surface. You cannot give this for class 1 and class 2, because class 1, class 2 there is no protein at the cell surface. Okay. So for class 4, class 5 you can use ivacaftor, which it will potentiate the chloride channel function of the CFTR protein. Tezacaftor is another drug. It will cause the trafficking of these CFTR proteins in case if it is a trafficking defect. So it is produced, but it is not reaching the cell surface. Okay. So that is a class 2 mutation. So in class 2 mutation, it is a trafficking defect. So tezacaftor can be used. So identification of which class of mutation is very, very important. So this is one another drug called as an elexacaftor. So many newer drugs are coming up, and which will definitely change the way we manage, which are definitely changing the way we manage cystic fibrosis in children. So coming to antenatal testing. So when do you test for children? Routinely we do not do, but in our country, in case you have a sibling who is already with CF, when both parents are carriers, or when there is a fetal ultrasound which is showing a hyperechogenic bowel, dilated bowel loops, absent gallbladder. This is very important because many a times we get antenatal ultrasounds from obstetricians who ask us like, should we do anything for these reports? So we have to ensure that these children go and get once the babies are born, the parents get this newborn screening test is very, very important. So when you find in the fetal ultrasound a hyperechogenic bowel, a dilated bowel loop, or an absent gallbladder, please do the immunoreactive trypsinogen test, which is the newborn screening test for cystic fibrosis. Okay. So we can do either once the child is born, we can do, that is the newborn screening test, or if this is very strong, then we can do in the fetal ultrasound if it is positive, or if the parents they want to get an antenatal testing done, they can get it done through either CVS analysis or through the amniotic fluid analysis. So CVS can be done pretty early when the parents already know that they are carriers, when the sibling, there is already an existing sibling with cystic fibrosis. CVS can be done pretty early at 10 to 12 weeks. So for fetal ultrasound showing these anomalies, usually it is well evident somewhere between 15 to 20 weeks, that is towards the anomaly scan period. So we can do an amniotic fluid analysis also. So newborn screening is done through the immunoreactive trypsinogen test. So this is a screening test and it should be done only in the neonatal period, not after that. Okay. So this screening test is usually done on day 3 to day 5. Okay. Not in the day 1, day 2. Okay. So it is done only after 48 hours. So it is done from the heel prick sample and the dried blood spot is analyzed for the trypsinogen. So what happens in child with cystic fibrosis? It will be high. So the immunoreactive trypsinogen will be high. This is the healthy control. This is the cystic fibrosis child. So it is high in these children. So you have diagnosed, you have treated. So how are you going to follow up? So cystic fibrosis children should be under regular follow up at least 1 to 2 months at a center who has expertise in this treatment of these children. And under follow up you can use the Schwarzman-Kuletsky score, which is the most widely used one. So they have many criteria and 25 points are given for each categories, and based upon that the child is given a score. So regularly pulmonary function test, radiographic screening and ultrasound abdomen, and the levels of blood sugar, calcium, LFT is done for these children. So the surveillance for infection or for growth of organisms is also done at each follow-up. So we do a cough swab or a throat swab. Then after physiotherapy will be done under every follow-up to see if there is any growth of bacterial organisms. So currently there is no cure for cystic fibrosis, but the survival is improving over the past decades. We saw that it has increased from the 3rd decade to the 5th decade almost over the last 50 to 60 years. So majority of deaths in cystic fibrosis children is because of the chronic infections which cause pulmonary exacerbations, principally because of Pseudomonas and Burkholderia. So the poor prognostic factors will be children who have a very early onset, who are severely malnourished, and they have recurrent episodes of pulmonary exacerbations, like 4 episodes of pulmonary exacerbations in a year, and colonization with Pseudomonas. So these are the poor prognostic factors for a child with cystic fibrosis. So I hope the management part of cystic fibrosis is clear for all of you. Thank you so much.